Evening, folks. David Rawson here with Bianca, Director of Communications. It's just a little after 7:30, and I'm under very strict instructions not to introduce Dr. Remmers in any way other than he's the old guy from Calgary who cares a lot about sleep apnea, and and he's a friend of our profession. And you need to know this man has worked tirelessly his whole life, and we are just so lucky to have him A, be a Canadian, and B, be supportive of our academy, and wants each and every one of us to do the best job we can as dentists practicing dental sleep medicine. Dr. Remmers' topic tonight is replacing AHI and CPAP with a more predictive index and a more effective therapy. Dr. Remmers, welcome back to the Canadian Academy, and it's all yours, my friend.
Thank you, David, my friend, and thank you, Bianca, for your efforts. I'm a physician. I'm approaching this whole field from a medical point of view, but my interest is in developing alternative therapies, alternatives to CPAP, and so oral appliances has been my focus for the past 20 years. I'm going to first tell you that I'm employed by ProSomnus Sleep Technologies. I'm their chief scientist, and so I have a big conflict of interest. I will not refer to anything from ProSomnus until the very end, and then I'll tell you exactly why I think the data that I will present to you is valid and I'm not conflicted. But moving right along here, the current state of affairs in OSA is chaos, in my opinion. I'm going to tell it when I give you stuff that's my opinion. I will let you know, and David asked me to just sort of cut loose and have at it, so I'm going to do that, but I'll let you know when I'm doing that. I'm still a data guy. I want to keep you in touch with the evidence and reality. So apnea-hypopnea index, it's of uncertain clinical utility. Everyone agrees with that. Continuous positive airway pressure, no evidence that it improves long-term clinical outcomes. I'll come back to why I can say those with confidence. So, and then lastly, is obstructive sleep apnea really a disease? I'm going to touch on that as well. So I think we are in a point of transition, and I want to tell you in tonight's presentation that not only is there chaos right now, but I think there is light at the end of the tunnel. It's not a locomotive. I think we've got some good stuff coming along. Sleep disorders are a major public health problem. That's from what I used to call the CDC, the preeminent public health institution in the world, I think. So that goes without saying. And then you know that there's this Lancet Respiratory Medicine that says about a billion people worldwide have sleep apnea, and most of them, the vast majority, are undiagnosed. These are allegedly facts, and I'm going to accept them as facts. Here's Bill DeMett for you. Sleep apnea remains the most undiagnosed deadly problem in medicine. He's the father of sleep, not sleep apnea, the whole field of sleep. And he ends up saying it's a medical problem. I'll buy that. I'm not gonna, that's uncontested in my view. Deadly problem, I'm gonna very much look at that tonight. And clearly there's a lot of folks that are undiagnosed. So let's start about, is it really a disease? A disease is any harmful deviation from normal function associated with characteristic signs and symptoms. It's a harmful deviation. Now, also there's not necessarily a sharp demarcation between disease and health. So that's a problem, like it is snoring, upper airway resistance. Are these diseases? Is OSA a disease? So, well, is sleep apnea deviation from normal? Yes, no doubt about it. Normally we keep breathing regularly all the time. And we have an interruption in pulmonary ventilation while asleep. That's not normal. So it's a deviation from normal function. So the central question is not, do we consider it a deviation from normal, but is it harmful? If it's not harmful, it's not a disease. You know, I can get alopecia, baldness, and you might not consider that a disease. My hair can turn gray. And there are a lot of things that happen to normal function that may not be a disease. So half of people with sleep apnea, as you probably know, are asymptomatic. And by that, I really mean they're not sleepy. So we don't have all consistent symptoms. What about the comorbid illnesses? We got a lot of them, as you know. Depression, stroke, heart failure, severe obesity, drug-resistant hypertension, coronary artery disease, AFib, and type 2 diabetes. All are co-travelers, fellow travelers with sleep apnea. Causal relationship, well, that's uncertain. So association does not imply causality. This means they travel together. Both features, both travelers could be the result of something else, a third influence. So it doesn't mean that sleep apnea is causing all these co-travelers. Possible. We have some evidence for hypertension and stroke, but basically we don't really know. So without having proven that it's harmful, we can, with comorbidity, we can ask now about, what about mortality? That's a biggie. So now we're going to go to the big hitter. And Mr. Clemens, Mark Twain said, don't go to sleep. So many people die there. What about mortality? Does sleep apnea kill people? Well, the answer is maybe. That's tough. We're now coming to the key feature of whether or not sleep apnea disease, and we have to say maybe. So it depends on how you measure the obstructive sleep apnea severity. And so that's very important. And we call that a surrogate index. AHI, apnea hypopnea index, is a surrogate index for OSA. And so let's take AHI as the surrogate index right now. I'm going to end up telling you it's not, but let's take that it is. And we're going to start with this cohort study. That means we take a whole bunch of people. In this case, it was 1,500 people, state workers in Wisconsin, and we do polysomnograms on all of them, and then we watch them for 18, 20 years. And we know which ones have no sleep apnea. They're the guys at the top here, and which ones have severe sleep apnea. They're the guys at the bottom. And so we look over the years and see what's the likelihood of surviving. How many survive? Well, and you can see things go along swimmingly for the first 10 years, not much difference between the two. And then this cliff arises, and the severe sleep apneics fall off the cliff and start dying out. And we have, in the end, quite an excess mortality between AHI greater than 30 and AHI less than 5. Okay, well, that was nice and helpful, but it's not been entirely replicable. So we have the Sleep Heart Health Study from the NIH, and it was a much bigger study and very, very well controlled. And it found that sleep apnea predicted mortality only in men 40 to 65 years of age. Gulp. All right, well, we still got something here regarding mortality. And other cohort studies have failed to demonstrate a significant relationship between sleep apnea and death. So the question is, do we have the right, do we really have a disease here? If it's not killing us, then we may not have a disease. That's the idea. So the first question that we're going to go to is, are we using the right surrogate index? In other words, when we call these people severe sleep apnea, is that the right thing? Is that the right group to call severe sleep apnea? We do it by the AHI, but if the AHI is not a good indicator of severity, then we got this mixed group here in severe. And so that's one very important question. What is it? Do we have the right index for severity? And what's the AHI telling us? You know it, lots of things. Pharyngeal anatomy tells us everybody with sleep apnea has a high AHI. They have a pharyngeal collapsibility problem or narrowing problem. It can tell us about loop gain, high sensitivity of the system, and other neural factors that are at play during sleep. Maybe that's true. So these factors influence the apnea hypopnea index. Well, what's the apnea-hypopnea index telling us? Well, it tells us about nothing about the depth and duration of the apnea-induced oxyhemoglobin desaturation. So it doesn't tell us how bad the apnea was. We just, as you know, we count up the apneas and the hypopneas, just count them up. Now, I'm going to turn to hypoxia because that would seem to be a thing that hypoxia, not apneas, kill people. You can have a 10-second apnea that falls in the definition of apnea, and it can happen repeatedly, hundreds of times per hour all night long, and it's not likely to kill you. Okay? It's way too brief of interruption in pulmonary ventilation. But desaturation and resaturation, so having the oxygen go down and then back up, appear to be particularly harmful. It's not my idea. That's the established good evidence. So would an index reflective of the depth and duration of apnea induced desaturations be a better predictor of mortality than AHI? I think you would agree that it probably would. So if we can get a hold of how severe the oxygen drop is and how long it is, that's likely to be useful. It's more like if you're going to talk about blood pressure causing strokes, well, you're going to talk about the measured blood pressure, not something else. And for diabetes, it's glucose. These are blood pressure and glucose are central to the pathogenesis of the disease. They're the things that come in, kill people, cause strokes, so on. So we need a simple index, and we haven't had one. We need a simple index of the harmful agent that reflects the risk of mortality. I'm saying that very clearly. It's something that reflects the risk of dying, like blood pressure and hypertension and glucose in diabetes. So let's talk about it. AHI or hypoxic burden. What's best predicts risk? Well, let's start with AHI, as I mentioned. An apnea is something greater than 10 seconds. Does not have to be associated with any drop in oxygen at all. A hypopnea is a 30% reduction in airflow with a desaturation, but a desaturation might just be as small as a 3% drop from the baseline. These are transient events, number one. They happen, they're events. And that we're going to count them up, which seems pretty strange. We're going to just ask how many times does one of these transient events happens? Nothing about how long or severe the event is. And they're completely arbitrary. Dr. Christian Guilleminault invented the apnea-hypopnea index. And it's not based on any evidence or anything like that. He invented it. I won't go into why he invented it, but he had reasons. He thought it would reflect, be consistent with the patient's symptoms. That's what he thought. And I call it, and other people call it, this is, and Christian did himself, Christian's great mistake. The apnea-hypopnea index is Guilleminault's great mistake. That's what, because it doesn't predict anything. It doesn't predict how sleepy the patient is going to be the next day. It doesn't predict really how the likelihood of comorbid illnesses. It doesn't necessarily predict the risk of death. It doesn't predict anything really that we want it to predict, except, of course, reimbursement. It's now what's accepted. And once you get something accepted based on even on flimsy evidence, but it's accepted because everybody uses it. It's kind of like a language. And I'm not suggesting that we're going to change the language tomorrow or should change the language. The AHI is here to stay, but you should look at it, I think, with a more jaundiced eye. And I'm going to tell you perhaps a better way to look at an index of sleep apnea. What about oxygen? Rather than arbitrarily defining an event, why not quantitate a continuous variable, which is oxyhemoglobin saturation? And it goes down and it comes back up. We right now look at time less than 90 saturation. That's standard. You know about that. But I'm going to introduce you to something that's called the hypoxic burden. I didn't invent this, folks. I'm just telling you about what's going on and the light at the end of the tunnel, so to speak. The hypoxic burden, and it's going to look, it's going to try to quantitate the imposition of low oxygen on the body, what it's doing to it. I'm going to refer you to a paper a couple of years ago, and it's, you can write down up there the reference. But if you go through the list there, you find some awfully big hitters and famous people. There's the White and Redline. Dr. Redline just gave the keynote address at the SLEEP 2022 meeting. Dr. Wellman is the leading investigator in the whole field. I mean, these are great people. So this is to be noted. There's nothing sort of sleazy or slouchy about this. So hypoxic burden is an index that attempts to quantitate the harmful effects of hypoxia resulting from sleep apnea. So we're not looking at a drop in oxygen that would be caused by emphysema. At night, the oxygen does go down, often in people with emphysema, particularly in REM sleep. But that's not what we're talking about. We're talking about the dip and rise in saturation that occurs from sleep apnea. These discrete events, respiratory events, they're interruptions in pulmonary ventilation that cause a drop in oxygen. So we're going to quantitate the drop in oxygen, not just count them up. We're going to actually see how long and how bad the drop in oxygen was. Sort of looks like this, folks. We have breathing at the top. Here's breathing in and out, flat line, no breathing. So during the period of no breathing, after the circulatory delay, the oxyhemoglobin saturation goes down, and then it comes back up. Usually it goes down slowly and up rapidly. So we're going to measure the area described by this shaded area, this dark area. And we're going to do that and average it over the night and divide it by the number of hours of sleep and come out with how bad the oxygen was during the dips, not between the dips, not other times. The dips are caused by the interruption in pulmonary ventilation here. And we're going to look at this area and ask, is that a good indication of anything that we want to? Symptoms, comorbid illnesses? But I'm going to tell you tonight about death, and that's what this paper was about. First of all, the relation, we're going to look at two cohorts. One is the famous heart-lung, the NHLBI sleep heart health study. I think that's the one on the bottom here. And at the top is a new study, 3,000 people who had strokes, and they're elderly people. And so first of all, I have hypoxic burden on the y-axis and apnea-hypopnea index on the x-axis. These are just what the people were at rest at their baseline study before they began to be followed until they died, until the study ran out. These are just what they were at the beginning. And you can see that kind of scatter plot between the hypoxic burden and the apnea-hypopnea index. Whoa, well, that tells you right off, we have the possibility of learning something and perhaps an index that might be useful, new. And from this study, this is one of the two studies that are reviewed in this paper. They went back and got the original data, and then they calculated the hypoxic burden, and then they looked at survival probability. Well, look over here. So this is the lowest hypoxic burden. The lowest, it's really a quartile, a quintile, 5 quintiles. So this is the lowest one in orange, and then green is more and more and more. And these top three are really kind of very low hypoxic burdens. And then we got a blue that's more, and then finally this purple one, which is the highest hypoxic burden. Don't worry about the numbers. We'll come back to those later. But low hypoxic burden, high hypoxic burden. Hypoxic burden, remember, is just the area under the dip, or circumscribed by the dip. It's how long and how bad the drop in oxygen was. And clearly, these two, the blue and or magenta, whatever that is, and the purple, they predict mortality pretty well. And the study, here's the famous quote from the study. I want you all to put it over your bed tonight. Unlike the AHI, very important start, unlike AHI, don't forget that. The hypoxic burden strongly, don't miss the adjective, strongly predicted CVD, that's cardiovascular mortality, and all-cause mortality. Folks, that's a really strong statement. That's an earthquake statement right there. So it says in their data, in their analysis of the sleep heart health study and this orthopedic study, and a total of 8,000 people in this totally, the AHI didn't cut it. It did not predict mortality. Whereas the hypoxic burden strongly predicted mortality. I didn't invent this. These are the best people doing this work, and that's what we have. We're going to need more studies, but right now, that's pretty impressive stuff. So I say this suggests, but does not prove, that OSA have harmful effects. We're still following this harmful effects because we want to know if OSA is really a disease or not. Causality, that is to say, the relationship between OSA and hypoxic burden and mortality, that causality can only be established by showing that if you get rid of the sleep apnea, you eliminate the harmful effects. In this case, you eliminate the risk of dying. So that's how we establish causality. So what I just showed you is maybe that's an association or a prediction, they call it. That's what the authors call it. But it's not proof. It raises your suspicion very much that the sleep apnea, and particularly the hypoxic burden, is having an effect that kills people, but it doesn't prove it. So we have to go to get rid of sleep apnea to prove this. That's proven to be tough. So I'm going to show you that as well. Does CPAP, which gets rid of sleep apnea, does it prevent cardiovascular disease? I'm not going to review the papers. There's more than I have right here. I want to lead you to the last one here. McAvoy, New England Journal of Medicine, the very best medical journal, 2016. And here you have it. Again, the most famous people in the world that are the authors here. And we have, 2,700 people. And we're going to randomize them. Either this is the way you do, you gather evidence, the only way you can. So you randomize it either to CPAP or to no treatment, usual treatment. And so we're going to do that. We're going to ask if the people who got CPAP don't get cardiovascular incidences. That's what we're doing in this particular study. It's not mortality. It's just looking at cardiovascular incidence over a period of about 48 months. So a lot of people with a good long follow-up, and we're going to ask, does CPAP prevent heart attacks, strokes, AFib, and so on? The answer is no, it does not. So here I've got, just look at the one in the center. The vertical axis is the cumulative incidence of cardiovascular events, bad things that happen from a cardiovascular point of view. And on the x-axis is months, out to 84 months. That's good. And you can see there's no difference between the group that were the people who were randomized to CPAP and the people who were randomized to usual care. No difference. These are people with moderate to severe sleep apnea, as indicated by the AHI. That may be the problem. But anyway, So conclusion, CPAP did not significantly reduce the occurrence of serious cardiovascular events. These were non-sleepy people and with moderate to severe OSA. Why not, you ask? It's a real scary thing. It should have. Why not? You say, oh, it's poor compliance. I know about CPAP. People don't use it. Okay, the average use was 3.3 hours per night. That's really on the borderline of what we call compliance on the medical side, compliance for CPAP. So I say the CPAP usage was low, but the results should have demonstrated some mitigation of cardiovascular incidents with treatment. Should, I mean, even though it's low, we should have seen some effect. The patients with AHI greater than 30 may not be the most susceptible to the mortality and cardiovascular effects of OSA. I'm speculating because we haven't been able to show it that consistently. So what we should have done in that study back here, we should have the CPAP, we should have selected for this population here, not people that had AHI greater than 20. That's what was so moderate and severe. We should have selected people with a high hypoxic burden. And then we probably would have seen something. That's an argument that I would make. I think people are making right now. So if we don't have the right indication of severity, then our studies that try to pick up, to try to prove that obstructive sleep apnea is harmful, well, they're flawed. So do remember that unlike AHI, this is going over your bed tonight, okay? Unlike AHI, hypoxic burden strongly predicts cardiovascular mortality and all-cause mortality. Don't forget that. Okay, is OSA really a disease? I say maybe. We haven't proven it yet, but we've got these strong associations. By the way, there's a recent paper on delta heart rate that shows the same thing. Delta heart rate as a result of an apneic event, that is to say. So delta heart rate related to sleep apnea, it also is a good predictor. So we're now getting to other things than sleep apnea that really make some sense. Just talking about how many times you stop breathing for 10 seconds or more is not really a good index. But now we're starting to get to some good indices. I've introduced you to the first one, hypoxic burden. There's going to be more. This is not the end of the story at all, but I want you to know that's what's new. Now I'm going to turn to what I call my musings, Remmers musings. First, I say, are the halcyon days of CPAP and AHI over? And I think possibly. I think we're at I call it chaos, but I think it's good enough to just say the halcyon days are over. We have a scathing report from AHRQ. That's an agency in the federal government of the United States whose job it is to look at the effectiveness and utility of healthcare interventions. And they note, after reviewing all the literature, CPAP does not improve long-term clinical outcomes. In addition, they note that there's no evidence that AHI is a useful surrogate. So what we're using right now is AHI and standard treatment of CPAP. There's really no good. It's not to say that they aren't good, not to say that CPAP can't mitigate death or comorbid illness. It's just to say that we don't have any evidence. We've had 40 years of using it though, and studies have been done, and so far we haven't been able to provide the evidence that we improve long-term clinical outcomes with CPAP, and similarly that AHI is a predictive, a correlative index of severity. So does CPAP reduce the hypoxic burden of OSA? Well, I think you need to take somebody who should be using CPAP every night. Some of them don't use it at all. Some of them use it 50% of them might use it half the night. And some may use it all night. But if you take the overall population, I think you'd have to say that CPAP probably does not reduce the hypoxic burden in many patients. For sure, if the patient is using the CPAP all night long, yeah, the obstructive sleep apnea is eliminated, and the hypoxic burden is gone. but we have a poor long-term compliance. And I would also note when people are incompliant, when they stop using the CPAP, it's usually in the latter half of the night or early morning hours when the REM sleep is particularly prominent, long and deep. So that's my feeling. This is just my views. They're amusing, so don't take it as anything more than that. And my also amusing is that if we use precision oral appliances, and now I work for a company that says they make really good, precise oral appliances that set the mandible exactly where you want it set, might they reduce the hypoxic burden? And the answer is we don't know, but we're going to find out. We have historical data that comes out of my previous affiliation, which was with Zephyr. We did a lot of work, and we can go back and analyze the effects of oral appliance therapy on the hypoxic burden, because it's not always efficacious. And so we can ask, how does the hypoxic burden respond, as opposed to AHI, respond to the oral appliance therapy? And then we are currently undertaking at ProSomnus a new study looking at the safety and effectiveness of oral appliance therapy and using our latest oral appliance, the EVO, in severe obstructive sleep apnea. It's a multi-center study with Eddie Saul, Stanford Centers, Harvard, Mount Sinai in New York, and University of Minnesota. 100 patients. And we will be able to also not just analyze it with respect to AHI, we'll analyze this with respect to hypoxic burden as well. So there'll be more information coming out about how the hypoxic burden of OSA is influenced by oral appliance therapy. Now I'm going to shift gears. I'm running about right on time, so I'm going to slow down here a minute. This is what Dr. Rawson wanted me to talk about. So my life in the past 20 years has been about trying to provide an alternative therapy. My history is that I kind of discovered sleep apnea 40-something years ago. The real understanding of sleep apnea was from work that I did. I invented the first, I did not invent CPAP, but I invented one of the first electronically controlled CPAPs, and one of the auto CPAPs that's still out there today. And so I've had a lot to do with CPAP. I understand it well, but I know that while it's 100% as 100% efficacy, that's to say, if you're using it, it'll get rid of sleep apnea 100% of the time. While that's the case, I know it's also barbaric. I know that it has poor compliance. I know that people don't like to use it. And there are many people in our society that do not get diagnosed or treated because they do not want to use CPAP. So having said that, then I'm looking for an alternative. And the alternative, as far as I'm concerned, has to be as good as CPAP. It's got to do what CPAP does. What does CPAP do? It has high efficacy. Remember, that's how well it gets rid of sleep apnea acutely when you first put it on. So it has to have high efficacy, it has to have good compliance, and in addition, it's got to be similar cost, and it has to also provide information to the physician. I'm going to use physician now because it's a medical disease, and ultimately the physician is managing the case, not the treatment provider, but overall managing the case. The physician does have from CPAP the beautiful feedback that occurs that's derived from watching the airflow all night long each night. I'll call it a CPAP download. And a CPAP download provides not only compliance, it says whether or not there's a human being breathing on the CPAP machine, does that perfectly, but it also says, is there a residual AHI for some reason? Is there maybe there's leaks or there's something wrong and the CPAP is not 100% efficacious? if it says that, then it can show you the apnea hypopnea index. And so the physician loves getting this feedback, but he finds out not only is the patient using the device or not, but is there a residual AHI problem? And they still believe in the AHI, no doubt about that. They want to know if there's a residual problem. So is the therapy not being 100% effective? All right, so that's what we must have. We must have a highly effective treatment, and it must provide some feedback to the physician. Well, I'm going to give you some insight into what I think is coming down the road regarding oral appliance efficacy. Traditionally, physicians have eschewed or shied away from using oral appliances because this is a survey that I did. They say doesn't work. That what they mean by that, it's not efficacious. It doesn't get rid of the sleep apnea. If I have a great treatment here that does the job, why would I want to use that CPAP, gets rid of the sleep apnea? Why would I want to use something that is not as efficacious? Well, maybe the answer is because the one that's 100% efficacious is not being used regularly. But in any case, we have to have something that has high efficacy. And up here, I say precision and efficacy. That is to say that the appliance I'm using is one that is made by ProSomnus and has this characteristic of being digitally manufactured. Well, first of all, teeth are scanned, digitally manufactured, and we know does a great job of positioning the mandible. This is data that I'm going to show you that I and my group carried out at Zephyr, my previous institution, previous company. I had no connection with ProSomnus, none at all. So I had nothing to be gained by whether the appliance seemed to be working well or not working well, has side effects or didn't have side effects. And that was not at all in my mind. So this is objective data, I believe. And here's what I want to show you. In mild to moderate patients, okay, that's mild to moderate means patients with AHI less than 30, 94% were successfully treated. So efficacy was 94%. By percent, I mean ODI, oxygen desaturation index less than 10. It was the same for AHI less than 10. And so that's this blue bar here. Look at that. We got efficacy that's almost up there to 100%. You know, that's where CPAP is, right up the top. They're 100%. Whoa. Again, I've been in this field for a while. And when I started it, this blue bar was down here at 50%. So we've been gaining ground. Why, I don't know exactly, but I do know where we are. So this was the results of objective, prospective NIH level study, FDA level studies carried out by people who had no vested interest in the appliance at all. If you include severe patients, so now we have mild, moderate, severe over here, the yellow bar, 81%. That's still pretty good efficacy, but not quite 94. So we can say that with at least this appliance, the appliance we use here was not the current one that is made by ProSomnus, which is called Evo. It's the one that was the precursor to it, but the same general construction and characteristics. Okay, so I'm delighted by this. For everybody, the field says we can say we now have an appliance that we have a treatment using all appliances that have high efficacy. Wow. And for mild to moderate patients, it's equivalent or on par with CPAP. We're here. We made it with regard to efficacy. Here's the results of some of the more subjective features. Snoring, 97% of patients reported decrease in snoring. This is before, and this is no appliance with appliance. Snoring goes down in everybody. That's good. It's a big problem. Goes down in everybody. That's objective data. That's what we observe. We measure snoring. Here's reported improvement in sleep quality. Lots of them, 70% almost, reported improved sleep quality. That's good. And finally, improvement in daytime energy, 60% did that, showed that. So our symptoms are improving. And overall, most patients, like I think 90%, 85%, let's say, reported their judgment that the treatment met their treatment goals. It got us where we wanted to be. So that's very cool. I have another slide which didn't make it here. So I've got a number of these versions floating around. So I will conclude by telling you that I believe that we have a treatment, oral appliance treatment for obstructive sleep apnea that is about as effective as CPAP. It's probably going to be as effective or more effective than CPAP. Now, by effectiveness, I mean that you not only have efficacy that's high, but as well, you have compliance. So any treatment that's going to be effective, that's the word we use, it means long-term good outcome. Anything that's going to be effective, you have to have a treatment that has high efficacy. It gets the job done when you're using it, and you use it. So I think we have now, are approaching oral appliances that are as effective as CPAP, at least in mild to moderate patients. So this is a new day, okay? There's no idea that oral appliances don't work. No, sorry, they have the same efficacy and probably higher effectiveness. So that's the fundamental message that I wanted to leave you with tonight. I would also leave you with the notion that all of this is going to be looked at through a different lens, not the AHI lens. We're going to see a progressive shift from AHI to something else, other indices. So just be aware of that. That's what's going to be happening. And that can change everything that I've just told you in conclusion, because I was talking about mild and moderate sleep apnea, and that's done by the AHI. So whether or not that we continue to talk this way or not, who knows? But I'm pretty confident that we're going to have new indicators of risk for cardiovascular disease. So you're going to treat somebody with an oral appliance, and you may have an AHI, quotes, that is not less than 5 or less than 10. But that's really not going to be the question. The question is, what's the risk for this patient of comorbid illness or of death? And you're going to judge that not by the AHI, because it's not a good predictor of that. You're going to judge it by something like a hypoxic burden or delta heart rate. There'll be other new indices coming along. So I just want to let you to be aware that that's going to be coming in. And right now, we're in a transition period. And I think there is light at the end of the tunnel. It's not a locomotive coming at us. I'm pretty sure it's really a different approach to quantitating the severity of sleep apnea and assessing the risk. So with that, I will stop.
Great presentations, John Viviano here.
Oh, hi, John.
I'm curious. I mean, this is fantastic and great news for oral appliance therapy and what the future holds. Question is, how receptive are your colleagues being, the sleep specialists in general, with regards to this shift and getting away from, well, it didn't get the AHI below, 5, and let's look at, oxygen. How receptive are they being? You must be having these discussions, and I'm just wondering how receptive they're being.
Well, I'll start by saying I just returned from Charlotte, the 2022 sleep meeting, the AASM, so these are the sleep gods, okay, sleep specialists. And I'd say that, let me first say that the keynote speaker was Susan Redline, who was an author on that hypoxic burden paper, who is considered the really preeminent epidemiologist in the field. She gave a talk that was very much like the one I gave here. The interest at our little booth, we had a booth as wide as this room here, not very much. It was a very productive meeting, and there were lots of leads, lots of interest from people who run sleep labs. That is, sleep specialists who actually run sleep labs and sleep centers. So, so far, so good. My experience has been horrible, John, for the past 20 years, whether it's been with home recorders or devices that predict outcome or whatever I've ever tried to do. I've got nothing but resistance from the sleep specialist community. So I guess I have to say that I'm still not optimistic, but I've been rattled a little bit because of the interest. This data that I presented that is about high efficacy is published. So it's in their journal of Clinical Sleep Medicine, 2 months ago or something like that. So you have to have the published data. You must have that. You must be patient. You must be, polite and nice, John. You got to do all those things, and I'm trying to do all those things. But surely there needs to be some change in attitude about CPAP being frontline treatment for mild to moderate sleep OSA. Okay, it's got to change, or they're just being crazy. We know that CPAP has real shortcomings, and we know that we have good efficacy and good compliance with these oral appliances, at least the ones that I'm talking about here that I've personally studied and published the data on. But John, you ask a very, very, very important question, and time's running out for me, John, not for you, for me. Okay, and so I really want to see an alternative, not a better one or not a preferred one. I want to see that we have a genuine alternative, and there's the whole new area that's of decision-making, clinical decision-making that's developing now. And I think that's going to play an important role. Dr. Almeida, and she's talked here to this academy, is a leader in that field. So watch what she's doing and maybe you've attended some of her sessions. So I would say that the science that backs up the notion that how you present information to the patient and how the patient makes decisions can improve outcomes. And so I think that's coming on board. There's no doubt about that. And CPAP versus oral appliance is just a classic. And lastly, there's all this stuff about unilateral hypoglossal nerve stimulation, John, and the INSPIRE approach. Well, their data isn't as good as this data here. Okay, so if you that's another point to make. The sleep physicians have kind of taken to INSPIRE for their CPAP failures with severe OSA, and they're dropping down the kind of criteria for doing the surgery. Well, if you look at it carefully, I'll guarantee you our data is better and we can be more comprehensive. They have to exclude a lot of patients. So those are the facts, but I'm also very aware of resistance. There's concern about, two professional groups. So we're going to have to figure out how to get these people working together, John. We have a very interesting, to John Rawson, I would suggest that perhaps at some point down the road, I don't know, a year or 6 months or something, have the group in Calgary give a session. And this group is combining in a therapy indifferent approach these two treatments, providing these two treatments to patients. So no longer, we sort of were pioneers in providing CPAPs and home testing to patients in Calgary. Well, what we're going to be doing now in at least one major area is we're going to provide the combination. Come into our establishment, and it doesn't matter whether you want CPAP or whether you want oral appliance therapy. We'll make them both happen. Either one happen for you. We're indifferent. We're agnostic about that. And hopefully we'll have methods developed in conjunction with Dr. Almeida that will talk about, that will present these two therapies to patients with OSA. There's a great need, but I'm also sure there's a great untapped interest and demand. People don't even know about all appliances, but they sure know about CPAP, and they don't want any part of it.
I think that last point is very important. When I look at the syllabus for the AASM meetings, going back years, there's so little in the way of education given to the sleep specialists with regards to oral appliance therapy. And these types of talks, like what you just did here today, is the type of information we need to be getting in front of these sleep specialists, in my opinion, for them to start taking it more seriously. Because I still, I get resistance today, 2022, that I shouldn't be getting with regards to whether an appliance is appropriate for someone or not. I mean, I understand 20 years ago, why that would have been there, but it should not be there at this point, and it is still.
Well, we're going to be trying to change that. I think we have the possibility. So there's a number of things that are going to change, but one of them is going to be efficacy of oral appliances. There's a lot of other things that are changing too with the search for a new index of severity and risk of long-term mortality. I am a believer that ultimately evidence runs the world. Evidence will change the world. So it's just a matter of when. So if we've got data like this gets replicated, and like I have on the screen right here, gets replicated, and it's incontrovertible. Ultimately, now it takes time, but I do know that just in medicine in general, that primary care physicians and sleep specialists will respond to the evidence. And so we plan to not only go to the sleep meetings, we plan to go to the primary care meetings, and we plan to be sure that everybody knows about this.
Thank you, Dr. Remmers. Can't wait to see what the future brings.
Right there with you, on bated breath, and we are. I mean, I'm creating a hypoxic burden calculator as we speak. Got a person doing that for us, and we're going to be able to tell you, and you may even ultimately guide your quotes titration of the oral appliance, not by an AHI, but by a hypoxic burden. I don't know, or something like a hypoxic burden. But for sure, when you're asking the question, is my patient at risk for cardiovascular complication, for instance, you're going to look at that rather than AHI. That seemed very clear to me. AHI has not held up as a predictor of all-cause mortality or cardiovascular mortality.
Well, you use that concept in the development of your matrix product because you attached it to ODI rather than, the AHI.
That's right. I've always been biased that way, but this is ODI still just counts them up, and we really, this is very, very special. We're not counting anymore. We're looking at how bad it is. It seems to me if you're going to predict outcome, death, things like death, you ought to be looking at the challenge or burden or whatever you want to call it. How bad is the hypoxia? That's what we're attempting to do. Not me. Again, I don't take any credit for this. I'm working now with the people who are doing it, but I take no credit for inventing, developing this. I'm just here. I'm the messenger, and try to be a fair and honest messenger.
Thank you, Dr. Remmers.